Everybody, welcome to the Neurocritical Care Section Journal Club for this month. My name is Salia Farouk. I'm the Neuro-ICU clinical pharmacist at Johns Hopkins Hospital, one of the moderators. Other moderators include Dr. Megan Barra from Mass General Hospital and Dr. Kent Owusu from Yale New Haven Health. We're excited for two recent articles that are very relevant to our practices. The first one is on effective continuous infusion of hypertonic saline versus standard of care on 6-month neurological outcomes in patients with traumatic brain injury that was just published in JAMA. That will be presented by Dr. Tia Bollard from Mass General Hospital. The second article will be on risk of overcorrection in rapid intermittent bolus versus slow continuous infusion therapies of hypertonic saline for patients with symptomatic hypernatremia that was also published in 2021 by JAMA Internal Medicine. That will be presented by Dr. Treasure Bright from UF Health Jacksonville. I would like to kindly ask if you guys could mute yourselves and also follow along on Twitter using hashtag NCSPharmDC. With that, Tia, if you're ready, please go ahead and get started.
Oh, can everyone hear me okay?
Yes.
Okay, great, thank you. Let me pull my slides up here. All right, wonderful. So thank you so much for the introduction. Today I'm going to be presenting the COBE randomized clinical trial. Traumatic brain injury, or TBI, as I will be referring to it for the remainder of this presentation, affects approximately 69 million patients worldwide per year. A common complication of TBI is intracranial hypertension, and this is actually the leading cause of death post-head trauma. Hyperosmolar therapy is a useful treatment modality in treating intracranial hypertension post-head trauma. However, the prophylactic use of hyperosmolar therapy is still controversial. As everyone on this call knows, hyperosmolar therapy works by creating an osmotic gradient between the serum and the brain tissue. We really have two major workhorses for hyperosmolar therapy: mannitol, as you can see here on the right, and hypertonic saline here on the left. And that's really what our presentation today is going to focus on. I've listed some of the common concentrations of hypertonic saline available here for your reference. And we know that this can be administered either by bolus or continuous infusion. Here I've listed 4 more recent studies looking at hypertonic saline for the treatment of intracranial hypertension post-TBI. So you can see here in the 4th column that the majority of these studies did include patients with severe TBI, and there was a number of different dosing strategies included between these studies. The first 3 did look at continuous infusion hypertonic saline, and the 4th did look at bolus dosing. Looking at the results all the way in the right-hand column over here, you'll see that the results between these studies are variable. So we did find that there were 2 studies that showed there was no difference in mortality. The second study listed here found that there was a 90-day survival rate that favored a continuous infusion. Of note, these were the COBE investigators back in 2017 as well. And then there were variable results regarding intracranial pressure, or ICP. What I really want to point out here and stress is that there's really not a lot of good information regarding the prophylactic use of hypertonic saline in our TBI patients. And so that brings us to the clinical question and the gap in the literature that this study aimed to fill. So when compared to standard of care, does prophylactic continuous infusion of hypertonic saline improve neurological outcomes at 6 months in our patients with moderate to severe TBI? This study was performed in 9 French university hospitals. It was investigator-initiated, randomized, parallel group, and open label. The research assistants who who were conducting the telephone interviews at 6 months were blinded to the randomization group of the patients. In order to be included in this study, patients had to be between the age of 18 and 80, have a moderate to severe TBI, and have presented within 24 hours of trauma. Patients were excluded if they had dependence on others for their activities of daily living prior to trauma, if they had a GCS of 3 with fixed dilated pupils, associated cervical spine injury, if they were expected to experience imminent death, pregnancy, and if they were having fluid retention already that would preclude the addition of sodium-containing fluids. Patients were randomly assigned in a 1-to-1 ratio to receive either a continuous infusion of 20% sodium chloride or the standard of care. And the standard of care did follow the Brain Trauma Foundation guidelines, and some of the modalities in these guidelines and employed in this study included boluses of hyperosmolar therapy, CSF drainage, decompressive craniotomies, moderate hypothermia, as well as boluses of sedation agents, just to name a few. Patients were stratified based on trauma severity and whether or not they received a bolus of hyperosmolar therapy prior to randomization. The authors chose to use 20% sodium chloride in an attempt to reduce the amount of volume that was administered with the intervention group. So after patients were randomized to the intervention group, they received a 1-hour bolus of the hypertonic saline based on their serum sodium at baseline, as you can see in this table over here to the right. I have listed in the right-hand column for all of these tables the 3% sodium chloride equivalent, just for familiarity's sake. After the bolus was finished, patients were initiated on a continuous infusion of the hypertonic saline, as shown over in the table to the right. And this was titrated to a serum sodium goal of 150 to 155 milliequivalents per liter. This continuous infusion was continued for at least 48 hours. Upon discontinuation of the continuous infusion, patients were monitored, their serum sodium was monitored every 8 hours for an additional 48 hours. And if any point during that time, their serum sodium was 140 milliequivalents or less, they did receive an additional 5-gram bolus, or the 3% sodium chloride equivalent of 167 milliliters. The primary outcome was the difference in the Extended Glasgow Outcome Score, or GOSI score, at 6 months after trauma. And you can see here that a favorable neurological outcome is defined as a GOSI score of 6 to 8, as shown down here. Again, the research assistants who were conducting the standardized phone interviews at 6 months to determine this score were blinded to the patient's intervention group. Secondary outcomes included serum sodium, blood osmolarity, and intracranial pressure. These were all monitored every 8 hours during the study period. Additional secondary outcomes at 3 and 6 months included mortality, place of residence, or whether patients were able to return home, autonomy and activities of daily living, or ADLs, and this was assessed using the CATS index, quality of life assessed using the short form 36, GOSI score at 3 months, as well as the duration of post-traumatic amnesia, and this was assessed using the Galveston Orientation Amnesia Test. The authors calculated the sample size based on the assumption that 70% of patients would have a poor neurological outcome. And so based on a relative reduction of 20% in that rate of poor outcomes, they calculated that they would require 185 patients in both groups in order to have an 80% power. The primary analysis was based on an ordinal regressional model, and it was adjusted for the factors listed here. And all of these different factors could potentially affect the primary outcome. The authors did choose this ordinal regression model based on information that is cited down here at the bottom. This was a secondary analysis of the crash data that actually showed that there was increased statistical efficiency and power when the GOSI score was analyzed using the ordinal regression model. Secondary outcomes were adjusted for the factors listed here on the screen. "393 patients were assessed for eligibility. 23 were excluded for the reasons up here on the screen, and this led to 185 patients being randomized in each group and also included in the primary analysis. There was a relatively low rate of loss to follow-up in the two groups, with 4 patients each being lost to follow-up. An additional 3 patients in the standard of care group did discontinue the studies for the reasons listed here. Baseline characteristics were similar between the two groups, with the exception of more patients in the intervention group receiving neurosurgery prior to randomization. Looking at our primary outcome, this study did find that in the intervention group, 32.6% of patients had a favorable outcome at 6 months. Again, that was a GOSI score of 6 to 8. And in the control group, 35.4% of patients had this favorable outcome. The test of proportional odds showed that there was no significant difference in the 6-month GOSI score between the two groups. Additionally, the distribution of GOSI scores was not significantly shifted in either group. As displayed down here at the bottom, we see the p-value of 0.92. This is a visual representation of mortality at 6 months, and this is the unadjusted mortality. So when adjusted for all of the factors that were listed previously, the study did not find that there was a statistically significant difference in mortality at 6 months between the two groups. Looking at intracranial hypertension as a secondary outcome, just to orient everybody to this graph, here on the y-axis, we have the percent of patients with intracranial hypertension. On the x-axis, we have time since randomization that goes up to 7 days. Yellow bars correspond to the intervention group. You'll see down here at the bottom that the mean duration of intervention was 2.7 days. And so when we look at the first roughly 3 days here, we do see that the patients in the intervention group, that less patients in the intervention group did have intracranial hypertension. However, when we get to around day 4, we do see that there are more patients in the intervention group that have intracranial hypertension. So looking around treatment discontinuation, we are seeing sort of a rebound intracranial hypertension at this time. The authors did have a hypothesis for as to why this occurred. So they believe that it was the accumulation of organic osmolytes, and that upon discontinuation and normalization of the serum sodium, that is what resulted in the rebound intracranial hypertension. Looking at blood sodium, again, just to orient everybody on the call here, on the y-axis, we have the serum sodium concentration, and on the x-axis, we have the time since randomization in hours that does go up to 152 hours. Here you'll see that patients in the control group had a serum sodium of largely between 140 and 150, and oftentimes their serum sodium was on the higher end of that range. And so depending on your institutional practices and your guidelines, this control group may or may not reflect your kind of standard of care TBI patient. Additional secondary outcomes are listed here. This study did not find that there was a statistically significant difference in any of these outcomes at both 3 or 6 months. Rates of adverse events were similar between the two groups. Patients in the intervention group, not surprisingly, more commonly had severe hypernatremia, defined as a serum sodium of greater than 160 milliequivalents per liter. Unfortunately, the authors collected serum chloride as well as pH, but did not report it in this study. And that's something that I really would have liked to have seen, because we know that with the administration of chloride-containing fluids, we could potentially induce a hyperchloremic metabolic acidosis. So that information would have been nice to see and assess what we're doing with the continuous infusion hypertonic saline. Treatments for intracranial hypertension are displayed here. We did see that patients in the control group, Patients in the control group did have more boluses of hyperosmolar therapy. This was statistically significant. Unfortunately, the authors did not report what was used, how many doses these patients received, or the dose of those agents. So it's a little bit difficult to interpret what was going on with these patients. While not statistically significant, numerically, more patients in the intervention group did receive CSF drainage when compared to the control group. Some strengths of this study include that it was a multi-center randomized trial with a low rate of loss to follow-up. The use of a functional outcome as a primary outcome is a strength because that's an outcome that is extremely clinically significant to our patients. The centers, when they were evaluated independently, did have similar results. And this is important because we did see that when an analysis of the ESSET trial was performed, that different practices between different institutions or different centers in the study can potentially really impact the outcomes. And so we did not see that here. Some limitations include that the time to from randomization to treatment was around 12 to 13 hours. And so this study does not necessarily preclude the benefit from initiating earlier prophylactic hyperosmolar therapy. We did also see a discrepancy between the rate of favorable outcomes with a study that was recently published in JAMA earlier this month, the TRACK-TBI study. So if you recall, patients in this study, roughly 32 to 35% of patients had a favorable neurological outcome at 6 months. When you look at the TRACK-TBI study, though, depending on the severity of trauma, 50 to 70% approximately patients had a favorable neurological outcome. So that does lead one to kind of wonder why there was such a discrepancy and why this study had much lower rates of favorable outcomes at 6 months. Some discussion points listed here. So we did see that patients in the controlled group more often received boluses of hyperosmolar therapy. Again, we do not know what was given to these patients, how many doses they received. So it's a little bit difficult to determine what exactly was going on in our control group and whether or not that applies to our standard patients. We did see that the intervention group had more neurosurgical interventions, and numerically more patients did receive CSF drainage. So this could potentially make it a little bit difficult to interpret the exact effect that this prophylactic hypertonic saline had on intracranial hypertension. As I had mentioned previously, the control group did have a serum sodium largely between 140 and 150, oftentimes on the higher end of that range. And so when comparing it to at least what I've seen here at Massachusetts General Hospital, we typically target a serum sodium in our standard TBI patient of 135 to 145. And so with the patients really being over and on the higher end of that range, I can't necessarily say that the patients in this control group really reflect what we will see here. And so depending on your institutional practices and policies, these patients may or may not reflect what is typically done as the standard of care at your hospital. And then finally, we did see that the patients in the treatment group did experience that increased intracranial pressure after day 4, and that was after treatment discontinuation. I did mention the author's hypothesis for why that occurred. However, I think it's important to take away that when we are thinking about using when we are thinking about using hypertonic saline prophylactically for our patients, this could potentially be causing more damage than benefit, because this is something that we really would like to avoid in our patients, this almost rebound intracranial hypertension. So to conclude, the study does not support the use of prophylactic hypertonic saline in TBI patients, because we didn't see that it improved outcomes at 6 months. And we did see that it actually had the potential to cause harm. So we saw that more patients experienced severe hypernatremia, as well as that increased intracranial pressure after treatment discontinuation. Further investigation is required to determine whether prophylactic hypertonic saline has a place in therapy. And with that, I would like to thank everybody for attending this journal club, and I'm happy to take any questions at this time.
Thanks so much, Tia, for that excellent presentation. You mentioned a little bit about our institutional practice of serum sodium targets in this patient population being more towards eunatremia. Has this study altered in any way how you might advocate for moderate to severe TBI patients, whether at our institution or elsewhere?
Sure. So I don't think that this study really supports the use of prophylactic hypertonic saline. So at this time, and because we did see that it did not improve outcomes and it could potentially cause harm to the patient, so we're not seeing any of that benefit that the study group had hoped to find, that at this point, I would not recommend the use of hypertonic saline for prophylaxis for intracranial hypertension.
Thank you. And my second question is, I think the authors of this trial looked at a lot of different variables. Are there any variables or laboratory parameters that you feel the authors should have potentially gone into more detail on that would have been helpful for you in better assessing the safety of this therapy?
Sure. So as I had mentioned a little bit earlier, I would have liked to have seen, and I know that the authors did collect this because they mentioned this in the trial, however, reported that it was for an ancillary study. I would have liked to have seen the serum chloride as well as the pH, because we know that with the continuous infusion of the chloride containing solutions that we could potentially induce a hyperchloremic metabolic acidosis. And so that would just be another piece of the puzzle when we're taking a look at whether this potential intervention or prophylaxis is safe or versus efficacious.
Thank you so much, Tia, for that presentation. I have one quick question for you. As you mentioned, the intervention group had a higher percentage of patients that had hypernatremia as one of the side effects. They reported up to 12% of patients had sodium levels that are above 160. How do you think that would, if you encounter a situation like that, that would change or limit your management of somebody with acute ICP crisis?
Sure. So if I had a patient who was having an acute ICP crisis, and you mean whether we would initiate like hypertonic saline or that they were experiencing hypernatremia?
So yeah, the question is, if this is something that they've actually utilized as a prophylactic measure, right, with now up to 12% of their patients experiencing sodium levels of up to 160, how do you think that's going to change our management if somebody in that group really needed acute management of ICP?
Oh, sure. So in that case, we would like to administer a bolus of hyperosmolar therapy, but I think that a serum sodium of over 160 would preclude these patients from getting a bolus of hypertonic saline. So in this case, we would probably have to go with a bolus of mannitol for that patient.
So I think one of the issues here is, right, that if we're trying to use prophylactic hyperosmolar, which it looks like this is something that they've used here, we're basically are gonna have that sodium gap that we like to use out of the equation now, right? Because that delta sodium, which usually helps with the osmolar shift and the utility of hyperosmolar therapy with sodium sodium levels will be gone. As far as using mannitol, the question now is that what's your osmolar gap, right? If your sodium is that high, then your gap may be also high, which means that your other option may be gone as well. So I think the question here is that the idea was to use this as a prophylactic measure to help with not getting people there. There was no difference, but what if there was a crisis, in these patients? Then I think the problem is that you've probably exhausted a lot of the options that you could already provide. And I think at that point, you were probably thinking about, reducing the metabolic demand of the brain, right? Using other, really getting away from the hyperosmolar agents, right? Thinking about your pentobarbital, maybe propofol, other agents and such. So, and yes, as you mentioned, they had that rebound hypertension also that they saw after day 4, which obviously is a problem if that is happening in our patient population. Thank you.
Thank you.
There's a comment in the chat.
Okay, so the comment is, why are we still doing research on sodium goals to prevent ICP or cerebral edema issues? And so I would probably say that we haven't really determined the optimal either dosing strategy, as in either continuous infusion or bolus therapy when I think I might need to get back to you on this one.
Chris, do you have any comments to be added to that question? And then there's another question for you, Tia.
Okay, sure. So does a certain sodium level correlate with better outcomes? And that I didn't see any information regarding a specific sodium level target when we are treating patients with TBI, but would certainly reference the guidelines, the Brain Trauma Foundation, as well as the NCS guidelines. Okay, and then, okay, great. Thank you for that comment.
Any other questions for Tia?
Okay, so another question. Curious if you have any limits at your institution in relation to the maximum rate. In our TBI patients, we often need rates up to 60 milliliters an hour of the 3% sodium chloride to maintain hypernatremia. And again, I'm sorry, I'll have to get back to you on our policy here at Mass Gen. Thank you, Megan. No maximum here.
All right, thank you so much. Treasurer, if you're ready, it's your turn.
Thank you.
Great job, thanks.
All right, can everyone see the slides here and hear me okay?
Yes.
Okay, excellent. So I'd like to start by saying thank you to everyone for the opportunity to participate in today's journal club. And I do want to apologize in advance for any coughing you may hear in the background. I currently have a bit of a mild cold, but with that, we will go ahead and get started. So to begin, hyponatremia is the most common electrolyte disturbance in hospitalized patients and is subject to considerable uncertainties in understanding and overall clinical decision-making. This is in contrast to the well-established treatment of hypokalemia, for example, where treatment initiation and control occurs without really any significant effort in clinical practice. What we know is that in the case of emergencies, treatment of hyponatremia is complicated by the fact that there is not really an easy or reliable or even validated treatment strategy at this point. Some common causes of hyponatremia do include hypervolemic hyponatremia, such as in the context of chronic renal failure, cirrhosis, or heart failure. You have euvolemic hyponatremia, so SIADH or adrenal insufficiencies, hypovolemic hyponatremia due to fluid loss or third spacing, or additional causes including dilutional hyponatremia as well as pseudohyponatremias. The classification of hyponatremia can be classified by serum sodium concentrations, in which a mild hyponatremia is a sodium serum concentration of 130 to 135 milliequivalents per liter, moderate being 125 to 129 milliequivalents per liter, and then profound being less than 125 milliequivalents per liter. So focusing on the overall clinical presentation, the practice guidelines currently recommend classifying patients based on symptoms and make recommendations for interventions accordingly. So for moderately severe symptoms, these include nausea without vomiting, confusion, and headache, while our severe symptoms include vomiting, seizures, and coma, for example. So to capture the current approach to hyponatremia, two sets of guidelines have been developed, one by professional organizations within the US and one from Europe. So both of these categorize treatment by symptom presentation, and both guidelines recommend hypertonic saline boluses for severe symptoms. For moderately severe symptoms, the American guidelines do differ by recommending a slow continuous infusion in contrast to the boluses that are recommended in the European guidelines. While both recommendations are physiologically justified, they are both at best supported by low evidence. So two major complications occur in hyponatremia. The first can be cerebral edema due to rapid increases in serum osmolality, and secondly, osmotic demyelination syndrome as a result of too fast increase in serum osmolality. What we know is that brain cells are able to gradually obtain a new osmotic balance with the interstitial space, and thereby just limiting the cerebral edema. In this state, brain cells are highly sensitive to any rapid changes in concentrations of the effective osmoles. And what we know is that rapid increases in serum sodium can lead to apoptosis of the astrocytes within the CNS, and this process culminates in osmotic demyelination syndrome. So to avoid these complications, it's currently recommended that correction not exceed 5 milliequivalents per liter during the first hour, 10 milliequivalents per liter during the first 24 hours overall, and then an additional 8 milliequivalents per liter during every 24 hours thereafter until your serum sodium concentration is 130 milliequivalents per liter. So the trial we're discussing today is the SALSA trial, which was a prospective investigator-initiated, multi-center, open-label, randomized clinical trial. And the purpose of this study was to compare the risk of overcorrection in rapid intermittent bolus and slow continuous infusion with hypertonic saline in patients presenting with symptomatic hyponatremia. So from August 2016 to October of 2018, patients in emergency departments were included in the trial. After September of 2018, patients in wards were actually included to increase overall patient enrollment. And after 2017, the authors actually went back and included an additional practice site again to increase the overall patient enrollment. To meet the inclusion criteria for enrollment, participants had to be adult patients with moderately severe, to severe symptoms and a glucose-corrected serum sodium less than 125 milliequivalents per liter. Additionally, the patient exclusion criteria are listed here for you as well. So patients were allocated to either the slow continuous infusion or rapid intermittent bolus groups in a 1-to-1 ratio. They were stratified based on their symptom severity, and the determination of the underlying cause of hyponatremia was accomplished by a diagnostic approach, which is basically just based on their history, the physical exam, as well as the labs. All patients were further classified into the following 5 categories based on their extracellular fluid volume status as well. So the authors calculated the required sample size for an estimated dropout rate of 15%, a two-sided level of significance of alpha at 0.05, and a power of 80%. And what they found was that 89 participants were required in each group to find a significant difference. Statistical analyses were performed on the basis of both intention to treat as well as per protocol because the overall dropout rate was expected to be high. The intention to treat population was defined as all participants in which the primary endpoint was available, and those participants were analyzed according to the groups in which they were randomly allocated to, regardless if there was a deviation from the protocol. The baseline characteristics and lab values were presented as means and standard deviations for continuous variables, as well as frequencies and percentages for those categorical variables. And the authors also conducted a post hoc analysis looking at 4 target correction rates, which were specified by time frame. So the primary outcome was the incidence of overcorrection at any given period. This was defined as an increase in serum sodium concentration greater than 12 milliequivalents per liter within the first 24 hours, or an increase in serum sodium concentration by greater than 18 milliequivalents per liter within 48 hours. Secondary outcomes did include whether the patient still had symptoms remaining at 24 and 48 hours after treatment, the time from treatment initiation to achievement of serum sodium concentration greater than 130 milliequivalents per liter, the incidence of target correction rate, additional treatment, osmotic demyelination syndrome, as well as the incidence of relowering treatment. So the treatment goals were to increase the serum sodium concentration level by 5 to 9 milliequivalents per liter and to achieve symptom relief within the first 24 hours. Additionally, it was to increase the serum sodium level by 10 to 17 milliequivalents per liter or to 130 milliequivalents per liter or greater, and to again achieve symptom relief during the first 48 hours. Symptom relief was assessed as either symptom resolution or the persistent symptoms of hyponatremia. So treatment initiation was based on symptom severity, and in the rapid intermittent bolus group, patients were given a 3% bolus and serum sodium concentrations were checked at predefined time intervals, and based on that serum sodium concentration at each interval, the trial protocol provided instructions on how to react. So for example, for the rapid intermittent bolus group specifically, you can see that if you had a 74-kilo patient that presented with moderately severe symptoms, the patient would receive a one-time 150 ml bolus of 3% hypertonic saline. The serum sodium level would be checked at 1 hour. If the serum sodium was now 120 milliequivalents per liter, you would rebolus the patient. If the serum sodium had increased to 123 milliequivalents per liter, you would just observe the patient and provide no additional therapy. And if it had increased to 128 milliequivalents per liter, you would begin a relowering therapy. You would continue down this algorithm, reassessing the serum sodium in each predefined time interval. So the slow continuous infusion group was very similar in regards to administering therapy based on symptom severity at presentation and reassessing that serum sodium concentration to guide further clinical decision-making, again, based on the protocol. So as an example for our slow continuous infusion group, again, if you had that same 74-kilogram patient that was presenting with moderately severe symptoms, that patient would receive a slow continuous infusion of 3% hypertonic saline at 37 mLs per hour. The serum sodium level will be checked at 1 hour, and if the serum sodium was now 120 milliequivalents per liter, you would maintain that current infusion rate with no changes. If it had increased to 123 milliequivalents per liter, you would stop the infusion and just observe the patient. And if it had increased to 128 milliequivalents per liter, you would begin a relowering therapy. Again, same as in the intermittent bolus group, you would continue down the algorithm, reassessing the serum sodium at each predefined time interval, just like in that previous group. So when we look at the overall study enrollment, 313 patients were assessed for eligibility, with 178 patients making it to randomization. 87 and 91 patients of the bolus and continuous infusion groups respectively were included in the intention to treat analysis, while 72 and 73 patients from the bolus and continuous infusion groups respectively completed the study and were included in the per protocol analysis. The main reasons for protocol violation were errors in performing instructions by the nurses and overall non-adherence to the protocol due to the physicians being unfamiliar. So overall, baseline characteristics were well matched between groups. Their mean age was 73 years and 45% of the patients were men. The most common cause of hyponatremia was SIADH in the bolus group and thiazide use in the slow continuous infusion group. The mean concentration for both groups was 118 milliequivalents per liter at original presentation. So for the primary outcome, which was, again, the rate of overcorrection, in the intention to treat analysis, overcorrection occurred in 17% of patients in the bolus group compared to roughly 24% of patients in the continuous infusion group. For the per protocol analysis, overcorrection occurred in 19% of patients in the bolus group versus 26% in the slow continuous infusion group. So overall, what we see is there was no significant difference in the incidence of overcorrection between either one of the groups. Looking at the secondary outcomes in the intention to treat analysis, there were no significant differences between the groups when looking at symptoms observed at 24 and 48 hours after the treatment was initiated, the incidence of the target correction rate or time from treatment initiation to that achievement of serum sodium greater than 130 milliequivalents per liter. Additional treatment was provided in 91% of patients in the bolus group and 75% of patients in the continuous infusion groups, respectively. In terms of safety outcomes, there were no events of osmotic demyelination syndrome in either group. And additionally, the bolus group did have a lower incidence of relowering treatment compared to the continuous infusion group, so roughly 41% versus 57% of the patients, respectively. So when we look at the secondary outcomes in the per protocol analysis, they are very similar. Again, there were no significant differences between the groups, looking at the observed symptoms at 24 and 48 hours, or the incidence of overall target correction rate, Additional treatment was provided in 90% of patients in the bolus group compared to 75% of patients in the continuous infusion group. And the bolus group did have a higher mean of additional treatments. In terms of safety outcomes, again, there were no events of osmotic demyelination syndrome in either group. And again, we can see here that the intermittent bolus group had a lower incidence of reloading treatment compared to the slow continuous infusion group. So roughly 45% versus 63% between the groups. So in addition to the definition of the existing target correction rate, the authors added 4 target correction rates, which were specified by the time frame. So they were defined as achieving serum sodium of 5 to 9 milliequivalents per liter within 1, 6, and 24 hours, as well as achieving serum sodium of 10 to 17 milliequivalents per liter or 130 milliequivalents per liter or greater within 48 hours. So what we see is in the intention to treat analysis, the proportion of patients achieving target correction rate within 1 hour was higher in the bolus group than in the continuous infusion group, so roughly 32% versus 17%. However, in the per protocol analysis, the statistical significance of achieving this target correction rate within 1 hour was lost. Additionally, there were no significant differences between the groups seen in the incidence of target correction rate at the 6, 24, or 48-hour mark. So what we see is in this randomized clinical trial, there were no significant differences in the incidence of overcorrection between the two groups. Both intermittent bolus and slow continuous infusion therapies of hypertonic saline were effective and safe with no difference in the overall risk of overcorrection. The rapid intermittent bolus therapy did have a lower incidence of therapeutically lowering the serum sodium concentration, and it did tend to have a better efficacy at achieving that serum sodium goal within 1 hour compared to the slow continuous infusion group. Taking these findings into consideration, rapid intermittent bolus therapy could be suggested as the preferred treatment of symptomatic hyponatremia compared to a slow continuous infusion. So overall, this trial had several strengths and limitations. I think this trial was clinically significant. It does add to the literature by being, to date, one of the first trials to compare intermittent bolus versus slow continuous infusion in patients presenting with symptomatic hyponatremia. Overall, the patients were well matched and had similar baseline characteristics between groups, including their age, overall weight, and mean serum sodium concentrations at initial presentation. The patient population did include patients admitted to the ED as well as those general ward patients, making the overall patient population more inclusive. Most of the patients were actually managed in the ED rather than in the ICU, so I think this also provides a little bit of insight on ways to avoid additional ICU resources in this particular patient population. In this trial, roughly 98% of the patients did receive the infusion of the hypertonic saline through a peripheral IV with minimal reported adverse effects. So I think this also adds some additional safety data with respect to line access. A significant number of patients were excluded due to protocol violations, and I think the overall exclusion criteria makes some of the conclusions a little less generalizable. Additionally, because the Korean patient population tend to have a smaller physique than Americans or even Europeans for that matter, I think the weight-based approach that was used here to prevent overcorrection may not be the same case for our patients here in America, so something to consider there as well. Additionally, because there was a pre-specified protocol which specified to recheck serum sodium concentrations at predefined time intervals, there was obviously an increased adherence to relowering therapy mandated by the protocol. And I think in reality, the utilization of relowering therapy is likely not as high as it would be, for example, in this trial. In both the intention to treat and per protocol analyses, roughly 80 to 90% of patients did receive additional treatments, which I think, again, limits the ability to judge this intervention on its own independently. Lastly, the primary outcome was a lab-oriented outcome rather than a clinical outcome, although it can be associated with patient mortality. I think it does make sense that the authors would choose this as the primary outcome since the actual occurrence of osmotic demyelination syndrome is low, but this still is, in my opinion, the most important outcome, especially considering the occurrence of overcorrection in this particular study was roughly 20 to 30%, and there were no events of osmotic demyelination syndrome, excuse me. So in conclusion, the findings of the SALSA trial failed to determine the best way to resolve hyponatremia symptoms. I think at best, rapid intermittent bolus therapy could be suggested as the preferred treatment of symptomatic hyponatremia, simply due to the lower incidence of relowering treatment provided and its tendency to better efficacy in achieving that goal serum sodium concentration within 1 hour of the treatment initiation. Personally, if I was asked to provide recommendations for rapid intermittent bolus, or slow continuous infusion in a patient that presented with symptomatic hyponatremia, I personally would recommend a rapid intermittent bolus. I don't think the results of this trial are compelling enough to recommend a slow continuous infusion. I think using rapid intermittent bolus limits the risk of overcorrection in the sense that you're not relying on labs to be drawn on time or even labs to be drawn at all to adjust an infusion. And I think we've all experienced in practice lab draws being an issue. So something to consider there. I know with the rapid intermittent bolus, you can essentially give the dose with no need for rate calculations or the concern that the infusion will run without being reassessed appropriately and adjusted based on the serum sodium concentrations. Additionally, we don't always have the luxury of multiple lines, at least initially on patient presentation, and being able to bolus something over 10 to 20 minutes versus running an infusion for several hours again provides another advantage to using rapid intermittent bolus therapy compared to a slow continuous infusion. And with that, I would like to thank Neurocritical Care Society, the moderators, and everyone in attendance today for the opportunity to present. And I'm happy to take any questions at this time.
Thank you so much for that presentation and discussing the flip side of sodium management in our neuro patients. One question I have is, does your institution currently use rapid intermittent boluses, or do they use a continuous infusion? And based on the results of this trial, are there any plans to adjust your current practices?
So while I don't have a lot of personal experience treating symptomatic hyponatremia, after having a discussion with some of our practitioners that do, it seems that we preferentially use bolus therapy compared to slow continuous infusion therapies for this particular patient population. Personally, as I stated previously, I don't think that the results of this trial would sway me to use a slow continuous infusion, just for the reasons that I stated previously, and I would still continue to recommend the intermittent bolus therapy.
Thank you. And I think, as you mentioned, the need for additional treatment as well as relowering treatment was definitely high in both groups, even if they weren't necessarily always different from each other. Are there any suggested recommendations in adjusting the current bolus therapy recommended in this trial that you think would potentially offer more safe and efficacious treatment and less need for additional therapies?
The question was, would I change the protocol that the providers use within this?
Correct.
I don't know that I would change the actual boluses that they received because they were using essentially like a 2 ml per kilo bolus. I think my concern would be, as I mentioned previously, that the generalizability of this would be limited due to different BMIs, especially within the American patient population. So maybe if I had a patient that was much, much larger, that would be a concern. I know the authors did state if they did not have a weight on file, they would give 100 ml bolus rather than doing a weight-based one. So that's another consideration too. But that would probably be one of the things that would change my recommendation as far as the dosing goes.
And I have one last question before we open it to the floor. One trend I've been seeing over the past couple of years is nephrologists advocating for the correction of sodium no more quickly than 6 to 8 millimoles per liter every 24 hours. And this is very different than the correction targets or thresholds presented in this study. So can you describe the practice at your institution and whether it's reflective of this, or your thoughts of whether, the correction threshold is too high, or if you have concerns with the 6 to 8 threshold every 24 hours?
I personally don't have issues with the correction that was used as far as how it reflects the current recommendations, as far as like not increasing it more than like 5 within the first hour. I personally haven't seen our nephrology team here make recommendations to not increase it more than that. I know from my experience, at least in our emergency department, we are definitely a little bit more careful and try not to go over that 8 milliequivalents within the first 24 hours, and certainly not to the 10 milliequivalent mark that was used to initiate a relowering therapy.
Thank you. Let's see if anyone has any additional questions. It looks like there are some stated in the chat here. Chris asked, you said most patients were ED. Do you think such a protocol could help minimize ICU admission and possibly hospital admission?
Yeah, I think that was one of the interesting things about this was most of the patients were actually treated in the emergency department, a majority of the patients. And I think that that does offer some insight on how to manage these patients and how to preserve ICU resources, simply because there was no significant differences in the risk of overcorrection, and these patients were not managed in an ICU. So I think it does provide a little additional insight on how to manage these patients, and basically saying that they don't necessarily have to be managed in an ICU to avoid that risk of overcorrection.
Another question that just came through was, does your center use the DDAVP clamp method to prophylaxis against overcorrection, or did you have any thoughts on whether this would be useful in this setting?
So I don't know that we have used, at least in my experience, 2 months into my, or a month and a half into my PGY2, that we have used the DDAVP clamp method to prophylax against this. I know for relowering therapy, we do preferentially use the D5 versus using DDAVP for those patients that are corrected too quickly. As far as the clamp method to prophylax against this, honestly, I would have to look into it. I've never seen it utilized, but again, my experience here is a little bit limited to comment on that.
And on the flip side, another question that came in was, how many patients in the study crossed over from bolus to continuous infusion? At the submitter's institution, they typically treat symptomatic patients by giving them what I'm understanding is initial bolus and then starting a continuous infusion.
I would honestly have to go back and look at the crossover rate. I do not know off the top of my head, but I could definitely get back to you on patients that were crossed over either from bolus to continuous infusion between the two arms.
Great job, Treasurer. Just a quick, I guess, maybe last question. I think we have time for one or more questions. Great job presenting, the data on this trial and how they actually ended up restricting a lot of, their measurements for follow-up. And I think, as you mentioned, everything was pretty strict, and that's probably why the overcorrection probably didn't happen as much as we would expect to see in real life. They did, though, see that the overcorrection happened in about 17.2% of patients in the rapid bolus group. And then, as you mentioned, also the 24.2% that happened in the slow continuous infusion group. But then, as you also mentioned, the rates of ODS, or osmotic demyelination syndrome, was very much zero and minimal and not existing. Do you think when you read the trial, was that a surprise to you that they didn't see that despite some pretty, kind of observable rates of overcorrection?
So I think initially it surprised me, but when I did more reading about osmotic demyelination syndrome, in general, it seemed like because the patients presenting had that serum sodium concentration at 118, and they did have pretty strict exclusion criteria. I don't know that this particular patient population would have been at as high of a risk of it. So I'm not overly surprised that it didn't occur, just because at least the reading I did, it didn't seem like this patient population would have been at the highest of risk of developing it. And that's just based on my personal reading.
Yeah, exactly. I think you're right on absolutely the exclusion criteria was pretty extensive, right? And they technically excluded a lot of those high-risk patients, patients with cirrhosis, hepatic issues, malnutrition, that would expect to see those, osmotic demyelination syndromes, and those patients were excluded. So I think they did a good job of stratifying, who may be at highest risk. And as you also mentioned, obviously, they had very strict protocol for when to check sodium levels, how to go about basically relowering it and all of that. But you're absolutely right. I think it's just a matter of what patients they focused on. We probably have time for another question, one more question probably. All right. Well, it looks like there are no more questions. Thank you everybody for joining us this month, and hope to see everybody in October for our next Journal Club.